Welcome to Studious, where we believe physiology is not a subject to be memorized in isolation, but the fundamental explanatory framework upon which all clinical disciplines are built. Whether you are preparing for the USMLE, MRCP, PLAB, or managing patients on the wards, mastering physiological mechanisms is your key to clinical success. In this comprehensive review, we bridge the gap between structural anatomy and active clinical practice by exploring the essential principles governing human life. Rote memorization is inherently fragile. Facts learned without context are easily forgotten under exam pressure. Instead, by mastering core concepts from first principles, you can intuitively derive complex clinical presentations, pharmacological actions, and laboratory abnormalities. This masterclass establishes the conceptual infrastructure required for deep medical reasoning. We will journey through cellular dynamics, homeostatic architectures, signal transduction networks, and integrated organ systems. Get ready to transform your understanding of the human body and unlock true clinical mastery. Let's begin. All physiological processes begin at the cellular level, where the plasma membrane serves as a selectively permeable boundary. This lipid bilayer actively maintains an electrical voltage difference, known as the resting membrane potential, baseline measured at minus 70 millivolts. This critical baseline is established by the unequal distribution of ions, the high resting permeability of potassium leak channels, and the electrogenic action of the sodium-potassium ATPase pump, which expels 3 sodium ions for every 2 potassium ions brought inside. Mathematically, the Nernst equation allows us to isolate the equilibrium potential of a single ion, yielding approximately minus 90 millivolts for potassium and plus 60 millivolts for sodium. The Goldman-Hodgkin-Katz equation then integrates these individual potentials, weighting them by true membrane permeability to calculate the final resting potential. Clinically, this is where electrolyte imbalances trigger disaster. For instance, in severe hyperkalemia, the extracellular potassium concentration gradient collapses. This causes the resting membrane to depolarize, preventing excitable cardiac muscle cells from resetting their electrical gates, ultimately stalling the heart and triggering fatal cardiac arrest. Building directly on the resting potential is the action potential, a self-propagating reversal of membrane voltage that allows neurons and muscle fibers to communicate instantly. This all-or-nothing phenomenon occurs in distinct, tightly regulated phases. At rest, the membrane sits comfortably at minus 70 millivolts. When a graded stimulus depolarizes the cell to a threshold of approximately minus 55 millivolts, voltage-gated sodium channels burst open. This defines the rising phase, driving a massive influx of sodium that depolarizes the cell toward plus 60 millivolts. At the peak, sodium channels rapidly inactivate, and delayed rectifier potassium channels open. This initiates the falling phase, where potassium efflux repolarizes the cell. Because these potassium channels close slowly, the voltage temporarily drops below baseline, a phase called after hyperpolarization, before the sodium-potassium pump restores the ionic balance. This sequence is heavily targeted in pharmacology. Local anesthetics like lidocaine or bupivacaine bind to and block these voltage-gated sodium channels. This action completely abolishes the rising phase, preferentially blocking small-diameter, high-frequency firing pain fibers before affecting larger motor axons, providing a targeted block. To sustain these electrical gradients and drive biological work, every cell requires an unceasing pipeline of energy in the form of ATP. This bioenergetic pipeline spans 3 interconnected metabolic pathways. First, anaerobic glycolysis takes place in the cytoplasm, converting glucose into 2 molecules of pyruvate while yielding a net total of 2 ATP and 2 NADH. PFK1 serves as the rate-limiting enzyme here. Under aerobic conditions, pyruvate enters the mitochondrial matrix, converting into acetyl-CoA to fuel the Krebs cycle. This cycle's primary role is generating electron carriers, 3 NADH and 1 FADH2 per turn. Finally, oxidative phosphorylation uses these carriers in the inner mitochondrial membrane. Electrons flow through complexes 1 to 4, pumping protons into the intermembrane space to generate a potent proton motive force that drives ATP synthase. This yields a massive 32 to 34 ATP molecules. Understanding this pipeline exposes clinical vulnerabilities. Toxins like cyanide and carbon monoxide bind and inhibit complex 4, halting aerobic respiration instantly and forcing cells into anaerobic glycolysis, causing fatal lactic acidosis. Conversely, uncouplers like DNP or thermogenin create proton leaks, dissipating the gradient as pure heat instead of ATP. Cells must communicate reliably to orchestrate survival, utilizing specific signal transduction networks to translate extracellular cues into functional outputs. The largest family of cell surface receptors consists of G protein-coupled receptors, which feature 7 transmembrane helices. These operate through distinct alpha subunits. GS stimulates adenylyl cyclase to elevate cyclic AMP and activate protein kinase A. GI directly opposes this by reducing cyclic AMP. And GQ recruits phospholipase C to generate IP3 and DAG, releasing intracellular calcium. Next, receptor tyrosine kinases, like the insulin and growth factor receptors, undergo dimerization and autophosphorylation upon ligand binding, triggering downstream kinase cascades that regulate cell survival and cell division. For immediate, millisecond-level electrical shifts, ligand-gated ion channels open directly, such as the GABA-A receptor, which hyperpolarizes neurons via chloride influx when modulated by benzodiazepines or barbiturates. In stark contrast, lipid-soluble molecules, like steroid and thyroid hormones, diffuse completely through membranes to bind intracellular receptors. These complexes act directly as genomic transcription factors. Because they require new protein synthesis, their clinical effects are delayed by hours or days, but remain incredibly broad and long-lasting. The central organizing principle of physiology is homeostasis, the active maintenance of a stable internal environment despite an unpredictable external world. The stabilizer of this system is negative feedback. When a physiological variable deviates from its set point, a specialized sensor node detects the change, prompting a control center to trigger an effector response that physically opposes and corrects the deviation. Thermoregulation, blood pressure adjustments via the baroreceptor reflex, and blood glucose control are classic examples. In contrast, positive feedback acts as an amplifier. Instead of stabilizing the system, it drives a deviation further from the set point, amplifying the response until a definitive physiological endpoint is achieved. We see this explosive spiral in action potentials, blood clotting cascades, and uterine contractions during labor. A fascinating clinical exception occurs during the menstrual cycle. While low estradiol exerts negative feedback, sustained high levels switch into a positive feedback trigger, initiating the massive LH surge required for ovulation. Finally, feed-forward mechanisms provide anticipatory control, initiating protective physiological changes before a predicted perturbation even hits the body, minimizing homeostatic error. To evaluate homeostasis accurately, we must analyze the fluid environment where these exchanges take place. Total body water makes up roughly 60% of a standard 70-kilogram male, equating to 42 liters. This volume is divided into 2 primary fluid compartments: the intracellular fluid, containing 28 liters, and the extracellular fluid, holding 14 liters. The extracellular space is further divided into interstitial fluid and blood plasma. The movement of fluid between these vascular and interstitial zones is dictated by Starling forces across the capillary wall. Hydrostatic pressure pushes fluid out into the tissue, while oncotic pressure, heavily maintained by plasma albumin proteins, pulls fluid back into the vessel. Clinically, edema mechanics reveal exactly what happens when this delicate balance falls apart. Edema occurs whenever net outward filtration completely overwhelms lymphatic drainage capacity. This is triggered by 3 main pathological changes: elevated hydrostatic pressure, seen in congestive heart failure; severely reduced oncotic pressure, seen in liver failure or nephrotic syndrome, or massively increased capillary permeability, caused by inflammatory signaling during severe sepsis. While hydrostatic and oncotic forces manage fluid distribution across capillary walls, fluid movement between the extracellular and intracellular spaces is dictated entirely by osmolality. Water moves freely via aquaporin channels to equalize osmotic gradients, meaning shifts depend heavily on sodium concentrations. We can visualize these dynamics using a clear fluid synthesis matrix. When you infuse isotonic saline, it perfectly matches plasma osmolality. Consequently, the fluid distributes entirely within the extracellular fluid compartment, yielding zero intracellular expansion, making it the perfect choice for emergency volume resuscitation. If you infuse pure water or 5% dextrose, the glucose is rapidly metabolized, leaving pure water behind. This dilutes the extracellular space, causing water to distribute proportionally across total body water. 2/3 shifts into the intracellular space, and 1/3 remains in the extracellular space. Alternatively, infusing hypertonic saline dramatically increases extracellular osmolality. This gradient forcefully draws fluid out of the intracellular space and pulls it directly into the extracellular environment, a high-yield intervention used clinically to reduce life-threatening cerebral edema. Transitioning to organ systems, muscle physiology illustrates how cellular excitability translates into mechanical work. In skeletal muscle, myofibrils are organized into individual contracting units called sarcomeres, bounded by structural Z-discs. These units contain thick filaments made of myosin and thin filaments composed of actin, tropomyosin, and the troponin complex. During contraction, the sliding filament mechanism dictates that the I band and H zone shorten, while the A band remains completely constant. This activating sequence begins when an action potential travels down the T-tubule network, triggering a massive calcium release from the sarcoplasmic reticulum via RYR1 receptors. This released calcium binds to troponin C, causing a conformational shift in tropomyosin that exposes the hidden binding sites on the actin filament. Myosin heads, energized by ATP hydrolysis, bind actin and execute the power stroke. Fresh ATP must bind to cause detachment. Clinically, if ATP is depleted post-mortem, myosin heads cannot detach, causing rigor mortis. Furthermore, genetic mutations in the RYR1 receptor cause malignant hyperthermia, an anesthesia-triggered state of uncontrolled calcium release, resulting in dangerous, sustained muscle contractions and severe heat production. Let's begin our high-yield systems atlas by examining delivery and gas exchange. The cardiovascular circuit functions as a closed loop governed by two foundational mathematical equations. Cardiac output equals stroke volume multiplied by heart rate, and blood pressure equals cardiac output multiplied by total peripheral resistance. Stroke volume itself is tightly controlled by three variables: preload, or venous return operating via the Frank-Starling mechanism, afterload, representing systemic resistance, and intrinsic contractility. Second-to-second blood pressure regulation is managed by the negative feedback loops of the baroreceptor reflex. Running in parallel is the respiratory interface, designed for oxygen delivery and carbon dioxide clearance. Alveolar oxygen tension is calculated using the alveolar gas equation. True gas exchange across the blood-air barrier follows Fick's law of diffusion, meaning efficiency depends on total surface area, membrane thickness, and concentration gradients. In clinical settings, ventilation-perfusion matching is absolutely vital. Any significant VQ mismatching disrupts this delicate exchange balance, making it the single most common cause of hypoxemia encountered in clinical medicine. Next in our systems atlas, we examine integration and metabolic regulation. Renal physiology focuses on filtration and fluid balance. The glomerulus filters blood at a normal rate of roughly 125 milliliters per minute, tightly regulated by altering afferent and efferent arteriolar resistance. The loop of Henle then acts as a countercurrent multiplier to build a concentrated medullary gradient. When the body is dehydrated, antidiuretic hormone acts on the collecting duct, inserting aquaporin 2 channels to concentrate urine and conserve water. The nervous system acts as the master integrator, split into sympathetic and parasympathetic divisions that exert opposing effects using ionotropic and metabotropic receptors. Endocrine physiology coordinates slower, widespread metabolic responses. The hypothalamic pituitary axes govern the thyroid, adrenal glands, and gonads through tightly nested negative feedback loops. Finally, gastrointestinal processing integrates neural control with powerful gut hormones like gastrin, secretin, and cholecystokinin. Notably, incretins like GLP-1 and GIP naturally potentiate insulin secretion. This physiological mechanism forms the direct foundation for modern GLP-1 receptor agonist therapies, revolutionizing type 2 diabetes and obesity management.
To track these integrated organ systems in a clinical setting, we must understand the tools on our physiological dashboard. The electrocardiogram records the heart's summated electrical activity. The P wave marks atrial depolarization. The QRS complex represents ventricular depolarization, and the T wave tracks ventricular repolarization. Electrolyte shifts modify this dashboard. For instance, hypokalemia notably prolongs the QT interval, predisposing patients to dangerous arrhythmias. Pulmonary performance is tracked via spirometry. An FEV1 to FVC ratio under 0.7 defines an obstructive lung disease, whereas a normal ratio, coupled with a reduced total lung capacity, indicates restrictive lung disease. To track hemodynamics in critical care, a Swan-Ganz catheter measures key filling pressures. The pulmonary capillary wedge pressure directly reflects left atrial pressure, allowing clinicians to differentiate cardiogenic pulmonary edema from non-cardiogenic causes like ARDS. Lastly, the Fick principle states that organ consumption of a substance equals blood flow multiplied by the arteriovenous concentration difference. This principle allows us to calculate true cardiac output based on arterial and venous blood gas measurements. True clinical competence requires linking multiple physiological steps together into an unbroken cascade. Let's synthesize these concepts by mapping out the heart failure cascade. The primary breakdown begins with a mechanistic failure, a severe reduction in left ventricular contractility. This causes a clear hemodynamic shift, resulting in a decreased cardiac output and a backup of volume that increases left ventricular end diastolic pressure. This volume backup travels in a retrograde transmission, forcing pressure backward into the left atrium and straight into the pulmonary veins. This culminates in a dramatic Starling shift. The elevated pulmonary capillary hydrostatic pressure completely overwhelms local oncotic forces, driving fluid out of the vessels and into the alveolar interstitium. This physiological shift produces the classic clinical presentation: acute pulmonary edema, exertional breathlessness, orthopnea, and bibasal crepitations. Every effective treatment targets a specific step in this cascade. Diuretics and SGLT2 inhibitors reduce preload and volume. ACE inhibitors reduce afterload to ease ejection, and beta blockers modify chronotropy and inotropy to protect the remodeling heart over time. In conclusion, true clinical mastery is built on 5 structural pillars: cell physiology, homeostatic regulation, signal transduction, bioenergetics, and fluid mechanics. If you memorize clinical facts in isolation, your knowledge will remain fragile and easily forgotten under the stress of board examinations or active clinical practice. However, when you prioritize the underlying mechanism, you build an unshakable foundation for all clinical reasoning. By mastering these core principles, you gain the ability to evaluate unfamiliar clinical scenarios, accurately predict drug effects, and deduce complex diagnoses from basic data. This is the explicit educational focus here at Studious. We want to equip you with the conceptual tools needed to move from basic mechanism to definitive treatment with absolute confidence. Thank you for joining us for this high-yield review. If this masterclass helped clarify these foundational concepts, please take a moment to like this video, leave a comment below with your thoughts, share it with your fellow students, and subscribe to Studious for more high-yield medical education.
We will see you in the next lesson.